This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hello friends, this is another case of Intumuscent Cataract which has a small pupil, and this was a 70-year-old lady. The antechamber is shallow, the lens is swollen, and the patient has pseudoexfoliation. That's the reason for the small pupil, and we also expect some amount of zonular weakness in this patient. The A scan does reveal a very shallow antechamber. It shows the antechamber to be around 2.48, and we need to manage the pupil as well as rhexis in this intumuscent cataract. So let's see how things go. After staining the antecapsule, I am using dispersive OVD to fill in the antechamber, and I am stabilizing the globe and creating a 2.2 mm posterior limbal incision. I won't want to stretch the pupil before inserting a pupillary expansion device, and my trick here is always to put some amount of cohesive OVD underneath the pupillary margin. It just lifts up the pupil, which helps us to be away from the antecapsule when trying to stretch it. I'm using Y hooks to do the stretching in this case. The stretching is usually done in 4 directions. Now is the time to insert the HEX ring. So I'm using the micro forceps to introduce it into the eye and place it onto the surface of the iris. After stabilizing with my left hand, the first pair of the notches are inserted behind the iris so that they engage the pupillary margin. Similarly, the second set of notches are engaged into the pupillary margin. I always prefer to use the side port to do all the maneuvers when trying to fix the HEX ring. That is really helpful for me. And once it is done, now time to do the rhexis. So before doing that, I'm just refilling the antechamber with OVD. I'm using Haldipurkar forceps to perform the rhexis. I'm puncturing it using the same forceps and then performing the rhexis. The plan is to do a 2-stage rhexis. I'm initially trying to do a small, around 3 to 4 mm rhexis, then decompress the bag and then enlarge the rhexis. So once the primary rhexis is performed, I need to decompress the bag here. Just trying to irrigate with my irrigation handpiece, just trying to push out some of the loose matter which is there. When I'm doing this maneuver, I'm also pressing down upon the posterior lip of the main incision so that the pressure is not built up. Then using the aspiration cannula, the bimanual I&A, I'm going underneath the rhexis margin and trying to aspirate some of the loose and fluffy cortex. I'm also tapping on the nucleus to gently loosen out the cortex which is there in the equatorial region, and by tapping and tilting the nucleus, some of the posterior cortex can also be maneuvered out and then aspirated. So once the cortex is aspirated out, now is the time to inject OVD again, and care is to be taken that we don't inject OVD in the bag. It has to be placed in the antechamber itself and prevented from any OVD getting into the bag. Again, after giving a tangential cut, I am trying to enlarge the rhexis. We can see that there are some capsular folds being seen when I'm trying to do the rhexis, suggestive of some amount of generalized zonular weakness. So the rhexis is completed. Now just want to enlarge it a little bit more, make it more symmetrical. Now is the time to perform emulsification of the nucleus. The nucleus is relatively quite soft in this case. I think the most difficult aspect, that was the rhexis in this case, was performed. The nucleus is quite easily chopped into multiple fragments and then emulsified with ease. So in such cases, you are dealing with a very shallow antechamber, small pupil. I think once you address these two issues, like taking care of the pupil and then also getting your rhexis right, rest of the surgery is just a cakewalk. So all the fragments are emulsified with ease, and then we aspirate just the little bit of cortex which is there, and then finally it's the time to implant the lens. Before that, I would want to put in a CTR in this case. I inflate the bag with OVD, then the CTR is inserted through the side port. I always prefer to insert through the side port. I'm using 2 forceps to do the job for me. So once it is threaded into the capsular bag, I use the Sinskey hook as an anchor so that the CTR guides into the bag, anchored with the support of the Sinskey hook. Gently, the final part of the CTR is nudged into the bag. Then the time to insert the lens into the capsular bag. A single piece hydrophobic lens is placed into the bag. I'm still not happy with the size of rhexis, so I'm just trying to enlarge it a little bit. Now is the time to remove the HEX ring, which is obviously the easiest part. You just disengage the notches from the pupillary margin and then pull the ring out. The OVD both in front and behind the lens is aspirated. And that's it, the case is done. Thank you for watching and hope this helps.